before we jump to what really patient-centered cancer care means, just to alert about something that is crucial in the world planetary, let's say, level. We're expecting an increase to cancer new cases. That is, the global cancer burden is to increase, and the cancer mortalities is also increasing worldwide. What that means? That means that we have a growing pressure on everything, but even this pressure is not distributed in an equitative way between low and high income countries. What this means that cancer will increase more in low income countries, and also mortality will increase more in these countries. So since the beginning, the system is not equitative. On the other hand, we have some good facts about the factors that influence this cancer burden. We know that almost 1/3 of the factors that influence the cancer burden are modifiable factors. That is where we're talking about tobacco, alcohol, excess weight, diet quality, physical inactivity, the air pollution. And we also know that 30% of the modifiable factors that influence the cancer burden are related to cancer-causing infections, that is HPV and hepatitis, and that vaccination can help control this rising cancer burden due to this factor. But the fact is that low-income countries have not such access to the broad population vaccination. To come back after this fact, just to come back to your question, what is the patient-centered cancer care? What this means in simple way, that means that the care is organized around the person, not just the tumor. It means that it integrates clinical effectiveness with the patient's goals, values, context, and support needs, and that treats patients and families as partners in the decision. That is, the best plan for a patient is clinically right and realistically livable for the proper person. And cancer care is not only what happens in hospitals or in clinics, but what happens in the patient's life in between visits. So those two contexts are creating the patient-centered cancer care. Non-medical factors that should be considered. Let's jump a little bit back of these. The so-called non-medical factors that shape the cancer outcomes are not really non-medical factors. Okay, we are nowadays integrating all these factors in our medical leading with patient reality. That is, the factors, for example, the non-medical factors in general are those factors that influence whether people can access care, understand it, adhere to it, and recover from it. So they can change treatment timing, completion, complication, risks, quality of life, and sometimes even survival. So those medical factors that shape cancer outcomes, but they are so-called non-medical, but indeed they belong to medical reality. We can name, for example, the health literacy and the several communication barriers that patients may face, like understanding the options they have, the side effects, warning signs. It is for sure the financial toxicity, that is the out-of-pocket costs, especially in low income. A typical example is the transport expenses that some people have to support in order to have access to the facilities. The geography The coastal areas, for example, or the very rural areas are non-medical factors that influence and shape cancer care outcome. The appointment burden, that is when somebody misses the visits, disrupts the treatment, the schedules, the proper work, the caregiving responsibilities, the social support a patient might have, the mental health, the distress, anxiety, the depression, trauma, fears of recurrence are all factors, non-medical factors, let's say, but influence and shape the cancer outcome. After we have the language, the proper language, the culture, the trust, the stigma that might be associated with the diagnostics, the misinformation, that's a huge problem nowadays. We have the digital access, inequities around telehealth or portals that might aid the patient take the more reliable information. And above all this, nowadays, those factors have been studied, and we have evidence, compelling evidence, that they are influencing in a huge way the outcome of the care. If you divide the patient care across the full pathway, the patient-centered care focuses on various levels. You can start from prevention and screening, okay, with tailored prevention, clear risk communication, and of course here we have the literacy, the health literacy issue, and the culture, if it's appropriate or not. And the patient-centered care means that we have to reduce the barriers to the proper screening with, for example, some reminders, flexible scheduling, transportation support. And at this point, we have to address misinformation and stigma, and we have to enable informed participation to the prevention and screening area. But those all these small points we can add go on to the diagnosis and treatment, the treatment phase of the disease. I mean, the most simple thing that I can recall right now is our proper communication with our patients that influence the decision-making. And this decision-making should be based in full and plain language communication, so the patient might be able to really understand and take his options and make his choices in full consciousness. After this, we have a patient care model requires a multidisciplinary care. There are no solos, there are no divas. We are talking about teams that study not just the case, but the patient, his social context, and provide the appropriate orientation about treatment, about all the pathway. Then during diagnosis and treatment, nowadays we have patient navigation programs, okay, that they help the proper patient coordinate and overcome the barriers, treat and lead with all the logistics that are around the proper diagnosis and treatment phase. And this might not seem so important, but I guarantee you is extremely important to guarantee the timing, the adherence of the patients, and this if they were directed to the more disadvantaged groups. Another useful tool we have nowadays to focus our care view to the patient is by measuring the proper patient's perceptions during this treatment. And this is the way we can improve the care we provide during this phase, during diagnosis and treatment phase, and act on areas that we might not have so great, let's say, performance, always from patient's point of view. And then if you want to go on, we pass on the other phase, that is the early palliative and supportive care for patients, okay? Not just treat symptoms. We're talking about symptoms relief, again, communication, again, support along all the therapy walk, disease, but mainly proper person-centered. There are a lot of trials around this phase. We have one very landmark, let's say, trial where it got very obvious that improved early palliative care, for example, can improve quality of life, reduce the end-of-life care needs, and it was associated with longer survival, okay, in patient care focus. We're talking about 4 months, more or less, of difference between people that enter in this pathway in the earlier phase of palliative care need and those that enter in a more late stage. And of course, we can never forget the survivorship issues. That is, on the patient-centered care point of view, we do not have just the disease, the treatment, and for those patients that are in need, the palliation. We have another big, that is probably the biggest part of patients, that when treatments end up, enter to what we nowadays call the survivorship area. Okay, survivorship is a completely distinct phase because their patients are out of the system, but they are still facing late effects and psychosocial needs. So they benefit from clear follow-up and coordination. And the late or long-term effects of cancer treatment have been documented. They are of high prevalence, and I guarantee you that they are late and long-term effects. There is this necessity to incorporate survivorship in the patient-centered care has been reported, like these patients that get lost in translation. And it's exactly what happens to these patients. Suddenly they can come out of the system. They still continue to face anxiety, uncertainty, long physical effects of treatments, but suddenly they are out of the system. So it's extremely important to know how to orient them and help them plan the after treatment period. Systems, specifically in European context, where we have this tendency to gratuity, we have a lot of points that really get problematic and really do not allow us to have this patient-centered care view, because we are full of good intentions, but good intent is not enough. Okay. Today, there is a huge problem of workforce that is crashing down. We have a huge problem of specialized workforce going through various countries, many times going completely out of Europe. So we are in lack of specialized workforce. And besides this hidden, let's say, this not very obvious problem, then we have, of course, the time pressure and other workforce constraints, that is very short visits with very crowded and not enough to fulfill the needs for us to assess the proper patient's needs. Then we have another crucial point, that is fragmentation between hospitals, primary care, and community services, because all of what the patient really needs or is fragmented, is working isolated. There is no a uniform path. And this inequity is even obvious, not just between countries, but inside the proper countries, inside the proper cities. We have neighborhoods with access needs very unsatisfied, and other neighborhoods, let's say, with access needs more than guaranteed. And this due to fragmentation and due to now uniformization and guarantee of quality of the services we are providing. Then we have the proper hospitals get paid, have their incentives from the government more because of procedure, or that is the system pays for the number you treat or the procedures you perform, more than thinking on the coordination or the navigation on this or the support that proper patients are in need. Then we have another huge problem that are the data silos, okay? We have a lot of data, but it works in silos and we do not have a correct information flow, not at the level of the countries, but not even inside the proper small hospital linked systems, not even for a proper, the unity for a patient. Many times we cannot catch the information available in primary care, for example, just as an example. Then, of course, another challenge the health system faces is as we're saying, the equity barriers. We have problems with language access. We have the problems meaning the inequity between the rural and urban areas with huge gaps. We have the digital illiteracy, let's say, issue. And then we have, to my point of view, we have the measurement gap. That is, it is not prioritized the patient feedback, the so-called the PROMs, the patient-reported outcomes and the experience. We need numbers if we want to evaluate what we are doing, what is working, and what we need to fix or to implement. And unfortunately, the collection of this data is not so much given of so much value. So more or less, those are the challenges that I see in the health system. As I told you before, we need, first of all, to have data, comparable, reliable, that tell us exactly what is working, where, and in what way it works. And there is something basic that WHO advocates, and I believe this is a principle of everything. We have the conscience that we are not able, like system, to guarantee everything in an equal way for everybody. But we are able to guarantee that what we can give is of the same quality. I mean, in different areas, different people with different types of tumors have need to different access to different treatments. What we need to guarantee, and this is our starting point, is that the quality of what we provide is of excellence. It might just be a small procedure that will how you say that will make the diagnostics. That is, you may in a city or in an area you may not have radiotherapy. Okay, so you cannot design the perfect surgery for as it was equal to someone who lives in a very big city with a lot of radiotherapy facilities. So what you need to guarantee is that the person that is in this area and cannot easily reach all the facilities is treated with quality in this proper area. Okay. If we put this like our starting point, I believe that we slowly can supreme and culminate the gaps we have, and to a future everybody to have the same access to the best that we can offer. But till we get there, I believe we have to focus on the quality of what we are delivering individually in each place. Let me tell you an example. It's extreme one, but you will understand what I mean. I perform surgical missions in sub-Saharan Africa, in a specific country that people there have access to nothing, not even in tissue histology. So you cannot have a diagnosis of cancer. You see, you suspect, you can even see the metastatic disease present without exam, just pure clinics, okay? But you cannot prove it. So you have to think in a systematic way what you need to provide to this person at this time in the place it belongs, and think also about the way that you might give some time to this person. So, of course, you cannot provide the same surgery that we provide in, for example, here in Portugal, like where I work, where we are minimally invasive. We need to provide not extended treatments because we're not sure on what we are treating, but extend enough to give to these people 1 or 2 years that they need to be evacuated from there to another country where they have the minimum requirements to treat a cancer patient. Can you see what I mean? But when I operate there, I operate with the same quality standards as if I operate here. Mm-hmm. This is the least we can do as healthcare providers. I have huge faith in the next generation of health professionals because I see that the youngsters are really interested, are more human than we are. And this is very encouraging. And I see that they are trying to have some balance in their life. And this helps them to be more empathetic with others and intend in a better way the needs and the huge need for the shift of our focus to the patient. When I'm teaching, what I'm trying to do is to help them think for their own, and to help them search for the information from reliable sources that, like I was telling you, the WHO is doing a great job on implementing guidelines and pillars of treatment. And what I believe that this next generation might be able to help humanity much more than we have done till today, just with small things in the small area that each one of us is acting. It's the view that we need to think globally, but we need to act locally. So I'm a huge fan of next generation, and I believe they are change makers. Another message I have to give for the youngsters that are studying, please always think globally. Do not think on your own. Act on your own unit, but think with a broader view. We just have this planet. There is no option B. Okay, we need to treat who is here with our mind always in the preservation of our house. Okay, we don't have other house. Is this? So we have to treat the inhabitants well and the proper house well. Okay, so that's all.